All right, good morning, students. We are going to be covering our materials and instruments for this surgical module. So we're going to kind of pick up where we left off last week when we were together. All right. So last time that we were in lecture, we were going over some basic surgical instruments. And we stopped here when talking about the surgical drapes. So now we're going to get into a little bit more of our materials and certain instruments that we're going to use when sterilizing, and then into basic examinations as well. So moving forward into covering sterilization instruments. So we're talking about different machines and tools that we use to sterilize instruments for surgeries and other procedures, which I was able to show you guys some videos last week of two different autoclaves that we commonly use. So we have the steam and we have the gas autoclaves. So we'll review autoclaves. I'm going to talk about that indicator tape that goes on our instruments, and it will change color when it is sterile. We also have chemical indicator strips, which is what we'll use for our gas sterilization, and then talking about that cold sterile tray sterilization method. So we know this is our autoclave, the autoclave that we're currently looking at. This is a steam autoclave. This autoclave is going to use high heat and pressure to sterilize the instruments that we put in there. We can either sterilize packs or we can do pouches, but we're never going to mix the two when we're doing the cycle. We know that when we do packs, it's going to take significantly longer, anywhere from a half an hour to an hour of sterilization, whereas in pouches are usually only 5 to 10 minutes. So difference in variations, as well as the pressure and heat for what you are sterilizing. And we're going to use this for all of our surgical packs. So our instruments we'll put through there, we'll put the gowns and the hand towels through our autoclave, our pouches with our individual instruments. But we have to be careful when using a steam autoclave like this, because we cannot put in materials that could possibly melt. So that being said, like plastic or anything that could possibly not do well under high heat. Now this is our indicator tape, and we are going to put this right on top of the pack like so. And this is what's going to help hold it closed when it's in the autoclave, but it's also going to have these white diagonal lines on this piece of tape. They've turned dark. And when they turn this dark color, that's how we know that it has been sterilized. So when we put it on, it looks plain. The stripes are going to be white. Once the steam hits and penetrates, it will turn dark in color. That's how we know that it has been effective. Now we're also going to use this tape to label our packs, because as soon as you've packed and wrapped it all up, it's pretty hard to tell the difference between, our different packs and what is inside. So we're always going to be labeling it, let's say if there's a gown and a towel, extra large gown plus hand towel, we're going to include the date. So, 1/26/22, and then your initials. For me, it would be SN. And that is to help us keep track of what's inside the packs, when we sterilized it, and who was the one that put the pack together. It's really important too that we have that date on there, because these packs only stay sterile for so long, depending on the way that you're storing it. So if you're storing these in an open space and it's not an enclosed container, sometimes these packs only last up to anywhere from 1 month to 3 months. However, if you have it in an airtight container where dust is unable to settle on these packs, they can be good up to 6 months to a year. And same with the pouches. We have to make sure that we're storing those accordingly. We don't want them out in the open where dust can settle and possibly contaminate them. We want them in airtight containers or up in cabinets where we can close the door and to where it's, it's not openly in the air getting exposed to possible contamination. Now with these indicator strips, we have our OK strips, which these are for our steam autoclave. And then there's also these Steri gauge, which are for the gas autoclave. So with these OK strips, we call them OK. They will say a big OK with an arrow pointing towards the K. As you can see, this is what they look like here before we've autoclaved them. So before we've put them through the steam autoclave, they're going to have that arrow and the K, they'll be white or kind of like a yellow in color. Once we autoclave it, it's going to turn to a dark color, and that's how we're going to know that we've successfully autoclaved our instruments. Same with the gas over here. It's going to tell us, it will change color and let us know if we should accept or reject the sterilization process if the chemical actually penetrated all the way through. And we will put these directly into the autoclave. We can put it right on the trays of the autoclave, or we can put it inside of our packs, which is kind of the most common method, is to put one inside of every pack, because even if the indicator tape changes color, that really only means that it was able to penetrate the outside of the pack, not necessarily that it got all the way to the inside. So we usually will put one of these OK strips right into that pack before we wrap it up in the drapes. But you can also just put it right on the racks in the autoclave. And it's going to be kind of up to your clinic and what their protocols are for their sterilization process. Now, the last method of sterilization, we have this cold tray. And with this cold tray, we're going to use a chemical solution within the tray that's going to help sterilize the instruments. Now, we usually only use instruments in these cold trays for wound repair, abscess repair, basically anything that's already running around with bacteria, to where we don't need something that's actually out of our autoclaves. And it can be a great way to save sutures. So sometimes when the doctor is suturing up the patient, they will actually need to open up 2 packs of suture because they only need, a little bit more for maybe a stitch or 2. So then you actually have an adequate amount of suture that's left over. So with that, we can actually just put those sutures right into the cold tray and keep them like so. And then the doctor can reuse it later when stitching up a wound or placing a drain, especially when you're dealing with injuries that already have bacteria within. Kind of our go-to. Now, we're not just going to take the instruments out of here and directly put them on our patient. We will rinse them off with water first. We don't want to take this chemical and put it directly on them. And you'll see they're few and far between. I tend to see that more old school vets will use the cold sterile trays versus newer vets. They would prefer just to actually put it through the autoclave, but it is a method that we can use, especially to prolong the life of sutures and have materials tools on hand to do wound repair, abscess repair, anything that's a little bit dirty. So now I'm going to get into some examination and diagnostics tools that the veterinarian and as well as us assistants are going to help use while we're doing the physical exam. So some certain tools that I'll help identify is centrifuge, the endoscope, laparoscope, laryngoscope, ophthalmoscope, otoscope, stethoscope, and tonometer. So with our centrifuge, this is what we're going to use to spin down samples from our patient. So not just blood samples, we can put urine and fecal samples into the centrifuge. So as you can see here, the tech is loading in these tubes right into where these slots are on the centrifuge. And really important that when we do this, that we have a balancer tube. So if you don't have 2 tubes, let's say you only have 1 tube of blood, you will grab another tube and fill it with water up to about the same amount of blood that's in the other tube. And it needs to go directly across from that tube to balance out the centrifuge. If you only put 1 tube in the centrifuge, it's going to be extremely unbalanced. The centrifuge will actually rock back and forth. And I have seen them fly right off the table. So we have to make sure that we're balancing them, even if we only have 1 blood sample. Now, some practices will have different centrifuges, like separately for urine or for fecal or for blood. They also have centrifuges that will have different inserts where we can use our microhematocrit tubes in there, which are very tiny glass tubes that we're going to use for the PCV-TP, which is packed cell volume total protein. And that is relative to our, if we couldn't run a CBC, we would want to do a PCV-TP. Now, guys, do you know what CBC is? It's a type of blood test. What is a CBC? I'll type it in the chat so that you guys know what I'm saying. What's a CBC?
Cell blood count.
It's not cell blood count, it's complete blood count, but we are counting the cells. The blood cells, we're looking at, yep, complete blood count, CBC. And we'll be looking at the red blood cells, the white blood cells. We'll look at the clotting factors and the platelets. So that's what we're evaluating when we're doing this complete blood count. Now, we will spin down our tubes, especially when we're running a chemistry. Those are kind of the two different blood testing that we can do that's most common in the practice is a chemistry versus a complete blood count. And the chemistry is going to tell us about the different enzymes and proteins and levels throughout the body so that we can evaluate organ function. So when we're trying to look at like kidney function, liver function, heart function, we'll be testing certain enzymes and proteins that are produced throughout the body. Now, the reason for spinning down these tubes is, especially with this tube that you see here, it's mixed with gray and orange. This is a tiger top tube. And so this tube is actually going to have clot activators in there. So as soon as we put the blood in there, blood is naturally going to want to clot, but this will ensure that the blood does clot inside the tube. And then when we spin it down, there's actually a little chunk of serum. They call it serum. It's basically just a gel, a white gel. And that gel is then going to separate the red blood cells from the serum, also known as plasma. But it's actually going to be serum in this sample. The difference between serum and plasma has what's called fibrinogen, which fibrinogen is really important to test, especially when we're looking at clotting factors, versus serum just doesn't, it will filter it out. And certain blood tests we will need serum for, and it can be more accurate to use serum over whole blood. We'll also centrifuge down our urine samples, and the reason for that, it's going to, as it spins at such a high velocity, these centrifuges, any of the solids that are in that sample are going to get pushed down into the bottom of the tube. So when we're doing this for urine, we're going to be making a urine sediment slide. So I'm actually going to take that sediment that has settled on the bottom, put it and mix it with purple dye and put it on a slide, and then evaluate it under the microscope. And that's a great way that we can use to test for crystals, yeast, bacteria, and getting that visualization under the scope. Now we can do the same exact thing with the fecal samples. So we put the fecal sample in the centrifuge mixed with, we call it the fecal solution. It's basically a sugar solution. And then centrifuge it down, the total solids will rest at the bottom. We can take those total solids and mix it with a dye and evaluate it under the scope. Same thing, looking for ova and parasites. So you will use this on a daily basis. All the time we're using centrifuges. Now the next examination tool I want to go over is the endoscope. So this instrument, we use this to give, basically it's a camera that we can insert into our patient, whether going through the rectum or down the esophagus or trachea, depending on what we're trying to get a good view of. And it can help us evaluate those certain organs, see if there's problems, rather than having to cut into our patient. So they can actually go all the way down the esophagus and into the stomach to evaluate the stomach. Let's say maybe we think the patient has ulcers, but we're not for sure. So instead of cutting into our patient and doing a very invasive procedure, we can use our scope instead. Obviously, we can't see everything with it. We're very limited with where we can use the scope, but it is a great diagnostic tool and a wonderful first step before we get into actually doing an exploratory surgery. Now, the scope up here, this is the controls. This is the handle that the veterinarian will be holding on to. And the scope will also connect to a large machine that can have water and air compressed. There is water that can come out of the end of this tool, and there's a little camera at the end as well. And usually we have a little screen. So as they're doing the endoscope procedure, it's going to be projected onto a little television screen so that the doctor can see what they're looking at. They can also look down through the scope if they have that eye tool at the end. But the benefit, if you put it up on a screen, you can also record it and send it off for further evaluation. So we commonly use the scope. They are really expensive though, so not every general practice will have them. Sometimes only specialties where you'll see it. The next instrument is our laryngoscopes, and we spoke about this in our Chapter 9 lecture. We use these laryngoscopes to view and facilitate the intubation process. So we can use it to view the vocal cords as well as just the back of the throat if we need to. but usually we're using this during intubation. So you can see here, there's an assistant holding open the mouth for the technician who's then holding their endotracheal tube and the laryngoscope. So this laryngoscope has a little light at the end, so it can shine down the throat. They can see the opening of the trachea and then be able to insert their endotracheal tube. And remember, this is the tube that we place into their trachea so that we can help them breathe. And that's how we're going to be delivering the anesthetic gas to our patients. You don't have to use a laryngoscope. You can do it without one, but definitely more preferred to have it. The tip of this scope is actually going to sit down on the tongue, so it can keep the tongue from getting in the way. And then of course the light can, definitely guide you putting in that tube as it's going to light up and expose where the trachea is. This next tool is the ophthalmoscope, and we will use this when performing eye exams. So in the examination that your doctor will be performing on every single patient, they should be using this scope to check the eyes. Regardless if the patient is coming in for an eye issue or not, we just need to make sure to get that closer evaluation. So they're actually going to look through this little sight up here. And this knob on the side, as they click it, it will change color. Also the brightness of the color, they can have it turn to violet or to white light or to no light. And it'll just help them get a better evaluation of the eyeball, making sure that there's no scratches or ulcers, and that it's looking like it's properly in good shape. And you can see here, using it on the dogs or the horses. And a lot of these tools here, like this ophthalmoscope, looking at our next tool here, the otoscope, the handles are usually the same. So you can use the same handle, but then just screw in another headpiece. So it's not a separate tool. It's the same handle, just a different piece that we're screwing into the top. So looking at our otoscope, this is what we're going to use to look into the patient's ears, all the way down into looking at the eardrum. So we'll use this in day-to-day exams. So doctors should be using their ophthalmoscope and their otoscope on every single examination of their patient, regardless if they came in for an ear or eye problem, to do a full comprehensive exam. Now, certain otoscopes actually you can connect it to a camera so that it'll display on a TV screen. This one has a little sight here, so they would just look through. Other otoscopes will have a light that shines through. So they do have a few different models. And again, it's usually the head will unscrew off, and it can be interchanged with otoscopes or ophthalmoscopes for these physical exams. Now we do have what's on the end of this tool is called an ear cone. And as you can see here, we have a few different sizes. So we will of course size it accordingly to our patient, smaller ear cone for our smaller patients, largers for our larger patients. And we'll clean these after every use. We're not going to be throwing them away, but we will scrub them out, clean them out before they're used again. And these are actually a great option. The ear cones I've commonly seen in those cold sterilization trays. They can sit in there, be rinsed off right until they're ready to be used. Next tool that we have here is a stethoscope. I know you guys are probably all very familiar with the stethoscopes. So we'll be using this to monitor and listen to the heartbeats, the breath sounds, and the gastric sounds. So with our heartbeats, we are going to be evaluating the BPM. Guys, what's the BPM? What's BPM? Beats per minute. Beats per minute. Yep. So we're listening to the heart and we're listening for the beats per minute. So what we're going to do with our stethoscope here is we'll place it onto our patient, ideally on the left side, right behind the elbow is where we're going to hear the strongest heart sounds. And we'll listen to our patient for 15 seconds, and then we'll multiply that by 4. The reason for that, take 15 seconds times it by 4, you get 60 total seconds. And it tends to be a lot more accurate when you do it this way versus if you listen to your patient for a full minute, especially if they're squirmy, moving around, this and that. So that tends to be the best way to obtain that beats per minute. And then with the breath sounds, we can use this to evaluate breath noises, making sure that they're taking adequate and deep breaths, especially if we are concerned with a respiratory issue. But we can also just sit back and watch our patient breathe to take the respiratory rate. Now, we'll also be listening to gastric sounds, especially if our patient is coming in for a gastrointestinal issue, vomiting, diarrhea. We want to listen to the guts and make sure that they are moving and still doing what they need to do. We call that process peristalsis. That is when the guts are contracting and relaxing in order to push the food through the body. I think somebody's unmuted. So if you guys could just check your Zoom real quick. Make sure you guys are muted. Wonderful. And then the next instruments here, we're looking at the tonometer. So this tool here, we're going to use to determine the ocular pressure of our patients. So looking at the patient's eyes and their eye pressure. Now, these are two different types of tonometers. I actually really prefer the one that's down here. This tonometer, it's going to have a probe at the end. And as they press the button, it's going to lightly touch the patient's eye over and over and over again for around 15 to 30 seconds, depending on the reader and how fast it can get that reading. And that's going to let us know about that patient's eye health, especially if we're concerned about something like glaucoma. This other tonometer up here, the difference between the two is this little probe will automatically come out and touch the patient's eye and give us a reading. This tonometer, we actually have to physically touch the eye with the end of the pen here. So it can be a little bit more risk and might be a little bit more uncomfortable for the patient, depending on who's using it and just the experience that they have with it. It will beep every time you touch the eyeball. So it'll tell you, how much pressure you need to give. It's very, very light pressure so that we can determine that. So just two different types. All right, now I want to talk about some IV instruments. So these are instruments that we're going to use to collect blood samples and to administer medicine intravenously. So we're going to look at two different tools here. We're going to look at catheters, we'll look at butterflies and IV catheters, and then getting into IV administration sets. And then I'll show you guys some videos as well on YouTube about blood draws and placing these catheters. All right, so the butterfly catheter. So we use this butterfly catheter when we are drawing blood from patients. Now, it's not something that we're commonly going to use like every single time that we draw blood. I personally recommend using butterfly catheters when we are going for the saphenous veins. Guys, where are the saphenous veins located? Saphenous. Where's the saphenous veins?
Isn't it on their back legs?
That's correct. The saphenous veins are on their back legs. What about the front legs?
Those are the cephalic veins.
That's correct. Absolutely. So the cephalic are the front legs, saphenous are the hind legs. Now, another follow-up question, which saphenous vein are we pulling from in the cat?
The left one? Wait.
I'm not looking.
The right one.
Sorry?
It's on the inner. It's on the inner, on the inner leg.
What's the term for inside?
Oh, I don't know that one.
Anybody help her out? What's the term for the inside of the leg? So with kitty cats, we'll pull from the inside cephalic vein. What was that? No? You guys should know this. Come on. Think of like cranial and caudal and dorsal and ventral. It's terms that go into that, like directional terms.
Medial.
Did you say medial?
Yeah.
Medial is the correct answer. So guys, when we are talking about the inside versus the outside, if I said you need to pull from the lateral saphenous vein, that means that you're pulling from the vein that's on the outside of the back leg. But if I said I need you to pull from the medial saphenous vein, that's the inside of that back leg. So really important that you guys know medial and lateral. We use those terms a lot, especially when pulling blood and when we're charting that. We do have to chart in the chart which vein we've pulled the blood from. So really important, we don't say inside or outside, we're gonna say medial or lateral. And then guys, just another question here, what's the veins on the neck?
The jugular veins.
Absolutely. How many jugular veins do they have?
2?
They have two, absolutely. So the jugular veins run bilaterally. So they run on both sides of the neck, the trachea, esophagus, that's what you're going to feel right in the middle. And then they run bilaterally down the sides. So they do have two. So if you feel on one side and it's not that great, the other side might be a lot easier to pull from. Good job, you guys. So real quick, I want to show you guys a video of, oh, not stop my share. Sorry, guys. I want to show a video of the blood draw with that butterfly catheter. It is a little bit different. I will always use a butterfly catheter when we are drawing from the saphenous veins. So those back leg veins, they're definitely going to be a really, really helpful tool when doing that. And then I'll also show you guys a video on a cat using the butterfly catheters. Standard every single time I pull from a cat, I'm going to use a butterfly going from those saphenous veins. And you'll get used to it. It's definitely a different and acquired feeling using these tools. I at first hated butterfly catheters. I didn't understand why we used butterfly catheters. I thought they just got in the way, too much tubing. But in reality, I started using them when I was at a cat specialty clinic, and I absolutely fell in love with them. They serve a great purpose. We can insert it into the vein and kind of let it be there. So if the patient does start to move, there is way less chance of us damaging that vein and possibly blowing the vein, which means we can't use it anymore. Not forever, just for that day. That is something that it's a great tool to use, especially if the veins are really small, or if you have a really elderly patient, the blood pressure is not that great. A butterfly can be a great tool to use for that as well. And this is Megan from @Dove. Again, another awesome YouTube channel that I really, really like is @Dove. They do a lot of videos talking about animal restraint, dealing with fractious cats, blood draws, catheter placements. So really great channel if you guys ever wanted to check them out.
Hi, I'm Megan. Today we're going to perform.
So she's going to do one on a dog, and then I'm going to show you guys a video of using the butterfly catheter on the cat.
From a blood draw from a lateral saphenous vein, and I'm going to use a butterfly catheter. I like to use butterfly catheters on smaller patients. The tendency to collapse the vein with a larger syringe is not there with a butterfly catheter. This also in a patient that may do a little bit of moving. If I've got the butterfly catheter in, he can move a little bit and it's not going to lacerate his vein. If I've got this syringe in there and he moves around, the chances of causing damage are a little bit higher. So I'm going to start by just putting a little bit of alcohol on the vein here. Then I'm going to take the cap off the end of the butterfly and hang on to that. Loosen the needle on my syringe.
So we can see this is the lateral saphenous vein running over around the hock area of that patient, and she'll grab the wings of that butterfly catheter, and that's what she's going to use to help drive that needle in to then get access to the vein. Yeah, I know the nails on this patient are really long. They're probably going to trim them after. Usually we'll end appointments on nail trims because nail trims can be really upsetting for our patients. So we'll get through all of the diagnostics and testing that we need to do, and we'll end on a nail trim more than likely. So as she inserted, we could see, let me just go back for 1 second. So as she inserts, as soon as it gets into the vein and there's vein access, the blood will start to flow down this tubing.
So once I get a good flow going through there.
And see how she can completely let go of this needle. It's going to stay within the vein. The butterfly wings are then going to come back down, and that can help stabilize it and keep it in place. Again, can be a way better option, especially if our patient's moving around. We don't have to be holding that needle directly into that vein.
Attach the syringe to the end here, and then just draw back. This also works well.
And personally, I would never leave air in the syringe. So right before the blood hits the syringe, I would disconnect it, then plunge all of the air out, and then reconnect to then get my sample. And that's just preference. Everybody's different.
On large patients, if they, their limbs are cold or they have a really low blood pressure and you're having a hard time getting a sample, I will often move to a butterfly. I do like to use a butterfly catheter in cats. If I need a sample larger than 1 ml of blood, I will almost always go to the butterfly catheter. And that's how we get a blood sample, using a butterfly catheter.
All right, so that's on our dogs. Again, that was that lateral saphenous vein. Now I'm going to show you guys a kitty cat, and this is the medial saphenous vein.
Okay. So we have Leo here, and we're going to go ahead and get a sample from him. I'm going to be using a butterfly catheter to get the sample from his saphenous vein.
So we can see that vein kind of popping up right there. And we do need to use that isopropyl alcohol on the area that we're drawing from that vein. It's going to, 1, flatten out the hair, and then 2, it also can help the vein pop up and become more visible. And then has that aseptic properties, of course.
So I've already got the area nice and.
Now hers is a little bit different. Her butterfly catheter, it's a little bit kind of has a harder piece tool right here after where the tubing starts. So just different manufacturers of the butterfly catheter, but it has the same purpose.
Moistened with some alcohol so I can find the vein a little bit easier.
See that.
And I'm going to insert the needle with the bevel up.
Guys, what's the bevel? She just said she's going to insert her needle with the bevel up. What's the bevel?
It's the opening of the needle.
Yeah, it's like the eye of the needle. Absolutely. So we want that opening facing up towards us that we can see, and then we'll insert. If we do it the other way, we could absolutely puncture right through the vein. We don't want that long side going in on top. She's actually having to, this is called a fanning procedure. So she's pulling back lightly and then inserting again. She didn't get the vein on the first insertion, which is okay. Cat veins are a lot smaller and can be harder to find. So she'll remove, lightly pull it back and then redirect it until she finds that vein. Right now, she's also taking her finger, refeeling for that vein, making sure that it's not just moving away from her needle as she's trying to plunge it. We call those rolly veins. And unfortunately, some patients have it really bad where you could try to puncture that vein and it just, so you're trying to puncture it and it just rolls away. Slippery veins. She's going to redirect. And then she got the blood. You can see that now it's filling that hub of the chamber of the butterfly. And she already had her needle and syringe connected. So you can start with it already connected. You don't have to, like in the other video, how she disconnected and then connected. You can have it all set up and ready to go. Sorry, my dog thinks that that's an actual dog. It's on the computer, hon. But as we can see, the blood's filling over here. And with cats, it's a way slower blood draw, you guys. The veins are so much tinier. This blood draw is going to be a lot slower. And of course, we want to keep it as calm and as easy for our patients. This is a really good kitty cat because if my cat heard a dog whining like that, she would bounce off the walls. So really, really well-mannered kitty cat. I know, Bella, but I know it's not a real dog. It's okay. Can anybody tell me what size syringe she's using? What size syringe does that look like? Any guesses? It's our most common common size of syringe we're going to use for blood draws, the most common kind and size. I'm not sure if someone was trying to talk. What was that? All good, you guys. When you are a little bit more experienced in the field and you're using these tools every day, you can tell by a glance, you won't have to look at the measurements. So this syringe that she's using, this is a 3 cc. And I know that just by looking at it at a glance. So our 3 cc's, that's going to be the most common size we're going to use for the blood draws. Usually that's the perfect amount that we need for our tubes. We can bump it up a size if we need to the 6 cc. Or if we need a small sample, we'll use a 1 cc. 1 cc's are way skinnier than the syringe here. And the plunger is really flimsy. 6 cc's are also a lot bigger, kind of in diameter. So again, you'll get better at it looking at them from a glance. But know that the size 3 is the most common. So she's just going to keep pulling, and then she'll disconnect. And I want to show you guys here. So then she's going to remove the needle. And as she does that, yes, cc is equal to ml. That's completely correct. And you'll see that I'll kind of bounce around. Sometimes I say ml, sometimes I say cc, but yes, it means the exact same measurement. It's just kind of a different way to say it.
And now that we're done, I'm gonna hold off and take out the needle.
So as she took out the needle, she made sure that she had a finger over where that needle was inserted into that vein. If we don't apply pressure to that, the blood will absolutely start coming out of that opening. And of course, we don't want the blood to get all over the patient. So we have to apply pressure. And then sometimes we'll also apply just a small bandage. So a cotton ball with some vet wrap, apply that pressure, wrap around them. So a pressure wrap, and then the owners can take it off the patient when they get home. Now, if the patient were to move around a lot while we were doing the blood draw and possibly has some bruising, that pressure wrap can really help with that. So some places they'll automatically have you do pressure wraps every time. Cats love to get them off. So sometimes we'll just put them on for like a minute or two and then take them off, or just hold adequate pressure with our finger or a cotton ball. That's what I wanted to show you for those butterfly catheters. And then I'm going to talk about a few more tools here, and then I'll show you an IV catheter placement. So different than our butterfly catheters, IV catheters actually go in the vein and they stay in there semi-permanently while they're in the hospital. So usually only about a week.
Ms. Nielsen?
So, yes, absolutely.
How long did it take you to hit your first vein?
Oh my gosh. Man, that was a long time ago. I was really, really lucky. My first hospital that I was at, I had a senior technician that basically took me under her wing and got to show me everything and was wonderful. I think it took me about 3 tries until I really got, was able to puncture into the vein. And a lot of that, you guys, it's just experience. It's just practice. And you will have those technicians or assistants that will take you under their wing and show you and guide you. You're never going to be expected to know how to do this right off the bat. I will tell you that it's a lot easier to hit a cephalic vein, so the front leg veins. Jugulars are really hard. That is something that I struggled with a little bit at first. And then got, over time got a lot better. Saphenous, because they're so tiny, can also be really hard to pull from. So I definitely recommend when you guys are first learning to learn off of the cephalic vein and practice on your big dogs first, practice on those big veins first, get the feeling for it, and then move down in sizes. And if they offer you guys in your externship to do it, please say yes, absolutely. Take as much knowledge as you can from anyone that you can. And know that it's okay if you don't get it on the first poke. Rule of thumb is you get 2 tries. You get 2 pokes before the next person. So if you miss it on your first poke, it's okay. Try it again. Now, IV catheters, that's what we're looking at right here. They come, this is just one variation. Sometimes they'll come in hard plastic coating case like this. Other ones will come in actually like more of like a plastic wrap. So just different manufacturers there. But these IV catheters, we're going to place them, the most common place we put them is into the cephalic vein, so into the front leg vein. We can also put them in the lateral saphenous in dogs. And in our livestock animals, we actually put it directly into the jugular vein. And I know that might seem a little bit intimidating. The reason that we do it in the jugular vein, think about horses. If we put that IV catheter in one of their legs, they could easily bend and rip that right out. If it's on their neck, it's in a place where they cannot turn around and mess with it, tear it out. So it's actually way safer in livestock to use the jugular vein. But in our dogs and cats, we'll use our cephalic vein. And again, dogs, if we need to, we can go to the saphenous vein. Cats, we don't really have much of that option. I have seen it done, but it is not an easy procedure to get in one of these catheters to their lateral saphenous. So again, it'll sit in there. It's got a plastic, basically a plastic casing around the stylet. That's the needle that's right here. And it will stay inside the vein and give us vein access. So we can use this catheter. This catheter, by the way, you guys, it's not taped in yet. So this is like, they just placed it and it's just having that vein access. We need to tape this in and apply a vet wrap bandage around it to keep it safe and in place so that it's not moving around. Now, I actually got into blood draws and got it pretty quickly with blood draws. Catheter placements was kind of my struggle at first. I could get it on some and not others. Cats were so hard because their skin is so much tougher. But again, over time, and the more often you do it, especially when I started working as a surgical tech, that is when I really started getting good at these catheter placements. I was doing it, you know, four or 5 times a day. Every single day working in surgery. So again, don't get intimidated by it. It's something that you're going to do over and over and over again until you master that skill. And you're going to have people in your clinic that are known for blood draws or that are known for catheter placements. You're never going to be great at everything per se. You're going to have your niches, your things that you excel in, and versus others that might be a little bit more of a struggle. And that's completely normal, completely okay. So let me show you here real quick a video of these catheter placements. Okay, perfect. And this is on a large dog, so we can see these veins really, really well. So again, I really recommend that you guys start off with large animals. They're going to have way larger veins. They're going to be way easier to hit, help build up your confidence before moving into smaller patients that are going to be a little bit harder.
Hi, this is Dr. John Imms, and today I'm going to talk about and show you how to insert an intravenous catheter and give you some tips on how to do this. Here we have a selection of intravenous.
So again, we can have the catheters that are in this hard plastic encasing here, but then they also come in just this kind of like more flimsy plastic casing as well. It's just different manufacturers, that's all. Optiva, Braun, and then I can't read the one on this one, but just different companies that make them. But these are actually, let's see here. This one, we can see the size here. It's a 22 gauge by 1 inch. This one here is another 22 gauge. This one here is a 24 gauge, and this one here is a 20. So we know that with our needle sizes, the smaller the number is actually the larger the needle versus the larger the number, smaller the needle. It's really similar with piercings as well. It's runs on that same scale.
Catheters suitable for use in small animals. They come in a range of sizes and lengths. The diameter of the catheter is usually called the gauge, and this is usually abbreviated to a G. The larger,
yep, so 24G, 24 gauge.
The gauge, the smaller the diameter of the catheter. Typically in the cat, we'll probably use a 25 gauge 90 millimeter length catheter, whereas in a large dog, we would use an 18 gauge 50 millimeter length catheter. There are 3 main parts to a catheter. There's the catheter itself, which is the part that remains within the vein. There's the stylet, which is the sharp metal needle within the catheter.
So I don't know if you guys can see this very well, but there's actually a plastic coating that's going over the needle, which is what we call the stylet, and that is the catheter. That's what's going to remain inside the vein. So when we give medications, fluids, it's going to flow through that. And it's really flexible. It's not like hard plastic. It is flexible, so it shouldn't be painful or anything for them. They can move freely with a catheter in. And as you can see, this is a very small tool. We have like a quarter right here, or a quarter size coin showing you just how big this size is.
Used to introduce the catheter into the vein. And then there's the stopper, which prevents blood leaking out at the end of the catheter once it has been inserted. This is Richie, a young Labrador about to undergo a general anesthetic. We're going to insert an intravenous catheter in order to give him the anesthetic and intravenous fluids during his surgery.
Keeping the tip of blades nice and flat. Cut the skin. Good. Yep, that's good. Yeah.
So when we place a catheter, we're always going to shave the area and then scrub the area. And actually with this one, I believe what happened was they're doing a teaching video. So the first person that tried to place it did not get the vein, and it's completely okay. So this is actually a senior tech teaching an assistant how to place this catheter.
Let me have a look. I can't really see from this angle. If we hold it up, probably just a little bit more on that
So
side.
you can see how she's holding up here, she's doing that rolling of the vein. So when you do that cephalic venipuncture restraint, you're going to be holding them in sitting or in a laying down position, and then holding at the back of the elbow. So their elbow should be right in the center of your palm. You're going to take your thumb over the front of the leg and then lightly roll the vein over. And that's going to hold the vein in place. So it'll kind of hold it taut and straight for the tech. And it's also going to help the blood pressure build up, which is going to make it easier for us to see the vein and then gain access. If we don't hold off on the vein, it's going to be almost impossible to place a catheter.
Side and then nice and straight there.
Yeah.
Okay.
So we can even see, just because this is a young, big, healthy dog, we can already see the vein that's the curvature right here. So already really nice, big, plump vein. And they're going to scrub it with their chlorhexidine and their
not too bad.
alcohol.
Right, I'll take that for you. That's got some mess on it, and that'll clear it and make it nice and shiny as well, so you can actually see the vein. Because he's got quite dark pigmented skin.
It does.
And so that can make it a little bit harder sometimes to be able to see the vein. Right, so yeah. Charlotte, are you able to reach?
I can try.
Okay, so holding the vein up.
So as soon as she holds the vein, you guys just saw it just rolled it over, made it straight, and now it's going to hold pressure. So we're actually going to see it a lot more apparent.
Oh,
The
good
tape's
boy.
gonna go
Okay.
all over the place.
So now you can actually see
So we can
the vein
see
quite clearly now that it's
beautiful
being
big
held
vein.
up.
Yeah.
Again,
And you can
so much less intimidating to practice on these big dogs, way less margin for error. But again, you guys are going to be learning, and don't be too harsh on yourself. It's an acquired skill.
see that's the upper reaches of it here.
Yep.
And it comes down, there's a branch down here and a branch that will go along there. When you're starting off, it's probably easier to come where the main part of the vein comes along here, where the two branches meet around about there.
And as they're placing this catheter, the student is going to try first, and she does not get the vein completely okay. It happens. And then the technician's going to come in, and she's actually going to use the same leg, but just move up the leg to place the catheter. So rule of thumb, you never start high. We always start low on the leg, because if you blow it or you can't get it in lower, we can always move higher. But if you start high, you can never go lower because of the direction of the blood flow.
Start as low as you can on the leg, because if you have trouble and you muck it up, you can always move up, because that's the way the blood flows up that way.
Yep.
Okay. Right. All right. All right. So your hands are clean.
Yes.
Nice and washed, ready to go. We have the tape ready here.
You can
Body
glove up, or
cover.
you can just wash your hands really well.
Wind catheter. But make sure that the bevel is upwards. Remember, flying
so
that.
So she's going to come over and try to place this catheter.
come in at an angle.
Yep, he's a big dog, so you can come in at about a 20-degree angle to the skin, and the vein will be.
So we can see
under
just the tip of the
skin,
stylet
a
there, and
little
then the
bit deeper
catheter is
than
what's
the
on top of
smaller
it.
dog with the cat.
Okay.
Now remember, keeping the fingers on the side so you can actually look for the blood at the same time.
Yep.
So what happens when she punctures in, she is not directly on top of the vein. It looks like it's kind of deviated to one side, which happens. This is where we would do that fanning effect. So trying to pull back and then redirect it. The problem with catheters is sometimes when you try to do that, it'll actually fray the end of the plastic, and you have to trash it and get a new one. So it is a lot harder to place these IV catheters versus a blood draw. Come on.
In.
So she's not getting any blood back here. If you're into the vein, it's going to flash the blood in the back of the
What, you've
catheter.
got some blood coming back there? You're probably not quite in. There's not enough blood.
So she got a little bit of a flash, but she might have just gone off to the side
Come back a bit.
and redirect.
See? Now angle it a little bit more to that side and down a bit. That's it. Now you're in. Now hold it steady and advance it up.
So she's trying to
Don't
advance
still
the
it backwards or
catheter,
the needle
but you
backwards,
actually have
because
to
you'll come out.
Yeah, you have to push it in a
It
little
should
bit
just
more.
slide in. If it's not sliding in, it's probably not in. Not
So it might have just nicked the side of the vein. It's not directly in the center of the vein. So we're seeing some of the flashback up here, but when she tries to advance the catheter in, she's getting resistance, which means you're not in the vein. If you hit into that vein, it's going to glide in really easily.
Not in? No, it looks like it's there. Pull them back together again.
Okay. Yep.
Come back out together. See if you've
All the
got
way
any
out?
blood coming out. I think I'll be guessing a bit, but
So it looks like the student did poke twice. She did try twice and did not get it, which is completely okay. You guys, catheters were not my strong suit. This is why we practice. And of course, having a senior tech being right there with us, helping us. And again, you might realize that when you start to do this, you are a natural at placing catheters. And that's awesome. Again, everybody's going to have their strong suits and acquired skills, but definitely don't beat yourself up. We always have that 2 poke try, and then it goes to somebody else. And that happens. And you know what? It's okay. Like I said, catheters were not my strong suit. So it took me a while to get pretty decent at placing them. And it was when I really started working in surgery, where I was doing it every single day, multiple times a day. That is when I really got good at it. Versus if you do one every month, that's not enough to really have that decent amount of practice with it. I definitely recommend start out with blood draws first. Once you get to know that cephalic vein, how it rolls, how it looks, and you get good at the venipuncture, then move into catheters. Don't start with catheters, get confident with your blood draws, and then move into it. And of course, you're going to have senior techs like this right there helping you right along the way. And again, don't get too in your head about it, because especially when it's your first time, we're not expecting you to nail it on your first time. That's how we learn. And I think that we learn from our mistakes a lot more than we learn from our successes. So it's okay. It's a trivial trial, do it again, repetition. You'll see that a lot in this field. So this senior tech is going to move up the leg. So you can see the 2 pokes here. So totally okay. She's going to move up the leg a little bit higher. Again, if we started up high, we can't go lower.
but we'll see how we go. It looked like it was there.
Watch right down here. As she hits the vein, we're going to see the blood that's going to appear in the hub of our catheter. So this is what's going to tell us, we call this the flash. When we see a flash like this, that's going to indicate that we're in the vein. Now, if it's a really small flash and there's only a little bit amount of blood, which that's what the assistant was saying earlier, that means that you could have just nicked the side of it. You might not be directly into the vein. If you are, you're going to note a large amount of blood that's coming out. And there is a cap here at the end, so it's not just going to spew out and go everywhere. There is a cap that's going to stop it. And then she's going to use those wings to then advance the catheter in. So she advanced it in. As soon as she pulls the stylet out, now we can see the blood filling up into the catheter. Perfect, it's in. The assistant also let go of that roll and then put pressure down here where the catheter is placed in that vein, so that hopefully the patient doesn't bleed everywhere. It's okay if they bleed and we get it and it gets on the patient. We're going to clean them off. It's no big deal. But ideally we want to not have it drip out of the end of the catheter. But this is a young patient, a large Labrador, so he probably has incredible blood pressure, which is a reason too for that large flash and then blood coming out of the catheter. But the assistant stopped it pretty well. So then they're going to take the cap and screw that cap into the end of the IV catheter. And then they're going to tape it in.
Hopefully you're going to get the tape in the right order.
And this is so true, you guys. Every vet is going to have a different way of taping in a catheter. There is no right or wrong way as long as we're getting the job done. So you'll learn more than likely a few different ways. I've been taught about 4 different ways on how to tape in a catheter, and I definitely have my preference and my favorite. So you'll find one that works good for you. Just know that there's multiple ways to do one certain procedure. As long as you're getting to that end goal and getting it done and the patient is safe, that's all that we're worried about.
Thin tape, fat tape, thin tape, fat tape. Did you see that?
Yes, I did. And I see you put a little V-shaped slit in it as well, just there.
So I'll do this as well. It's called an anchor. So a little slit. She needs to make sure that this catheter is not coming out though. So instead of letting go of the catheter, I would actually hold the cap with my thumb until I get this first piece of tape around, and then you can let go of it. But again, that's going to be preference, and kind of you'll have your own individual way of doing it.
Complicate things even more.
Oh yeah, that's right.
I would never.
And
leave the
that's how I
catheter
do it. And that's how I
exposed.
want everyone to do it around here. Okay, got it? But that was a good one because that showed all the complications, which is excellent, I think, in a video. Because, you know, if you show everything going hunky-dory smooth, it's not always like that. So it's nice to see how to sort of try and do the alternative plan B. There's always got to.
And this tech is being super real because it's very true, you guys. It's not perfect every time, you guys. I have placed catheters. I could probably do it in my sleep. And there are times, and I have my days where I go to place a catheter on a big, beautiful vein and I completely miss it. And I'm like, oh my gosh, are you like, what? So even when you have that practice, even when you have done it a million times, we're still human, you guys. And sometimes it's not always going to go perfect. It never will always be perfect. And it's also responsible of your restrainer as well. If your restrainer is not restraining adequately and the patient jerks back, even if you're in the vein, you could absolutely blow it and lose it anyways. So it's a combination of, you know, you as well as your restrainer and your patient. And it's never always going to be perfect, regardless of how much experience you have. So just be aware of that. But that is just a kind of example video of placing that IV catheter in our large dogs.
Can you cause any damage when you're fanning through a vein?
Absolutely. Yes. If we are not being careful when we're placing this catheter, and if that patient does jerk pretty bad, the rule of thumb is if they start to fuss with you, place pressure and remove the catheter right away. The last thing we want to do is splice and possibly injure any of the muscles or surrounding tendons in that area. And again, it's not like, you know, it's not like we do that on purpose, but it can happen. So we do have to be careful more or less with catheter placements because of that. But again, you guys, you'll build on experience. And if it happens, it happens. These are unpredictable animals. It's not going to be perfect every time. And certain animals are going to be more scared than others. And it happens, even if you have a great restrainer. All right, so we're just going to go, let's see here. All right, what I'm going to do actually right now is we're going to take a little break. We've got about 10 more slides left for the day. I'm going in increments of like 30 slides, how we did before. All right, so now we'll get back into the lecture after our break here. So again, we just watched a video and talked about the IV catheter placement. The next piece of equipment here, this is an IV administration set. So this is the tubing that we are going to attach to the IV bag. And then it's going to the other end will attach to the IV catheter. And this is how we can give our patients continuous IV fluids while they're being hospitalized or under anesthesia for a surgical procedure. So this top portion here, this is called the burette. And this is what's going to, that's how we can measure the drip rate for our patient if we don't have a fluid machine. This tip here will take off the cap. That's what's going to plunge into that 1,000 milliliter fluid bag. The water will then drip through the burette. We can watch the drip it'll then go through the tubing here, and the end piece here is what's going to attach to the cap of that IV catheter, and that's how we can give that patient those continuous fluids. Now, there's two different types of clamps that are on here. This clamp that you see here, this is a thumb clamp. So this is most commonly used. It's really easy to use. You can use it with just one hand. So as you are setting up or giving your patient fluids, you can hold the patient with one hand and then grasp this thumb clamp and just roll this piece down, and that will automatically unclamp the line, versus if you roll it back up again, it's going to clamp it and stop the flow. This port that you see on the side, this is an injection port. There's actually two of them on this IV set. And so if we are giving the patient IV fluids, we can actually give their injection of antibiotics or pain meds or what have you through the fluid ports. We don't have to disconnect them to give the meds and then reconnect them. We can give it directly into the fluids. Now, this is also going to depend on what type of medication we're giving. If we need it to be immediate, we might just unhook them and give it to them directly in their IV catheter. But these injection ports are there, and they're really, really nice to use, especially if the patient is fractious or aggressive. You can actually pull these pull the injection ports outside of the kennel and just give the injections outside the cage. You don't even have to touch the patient. So there are a lot of benefits for those. This is what we would call a macro drip set, because the opening for the fluids to come through is just a full bore open. Now, a micro drip set, which we might use on like small puppies or kittens, will actually have a small kind of like metal, almost looks like the tip of a needle coming out of here, which will prevent large amounts of fluids from coming through this set. So kind of a double wall to make sure that we don't accidentally give our patient too much fluids if we use a micro drip. All right, the last section I want to go over today is some dental instruments that we can use on our patients while we're doing dental examinations or dental cleanings. So I'll go over some for our horses and then some for our small animal as well. All right, now this isn't necessarily something we're going to use in a dental procedure, but it is an oral like almost like a pill gun that we use for our dogs and cats. That is the equivalent of that is a baling gun that we use in our cattle. And so this instrument here, we can actually load a pill into the end here and then use the end of the plunger to push it in, and that will release the pill and it can go down the throat. So it's really great when we have to give the livestock capsules or boluses, medication orally, rather than just sticking our hand in there. A lot safer to use the baling gun. Next instrument we're going to look at here, these are dental floats. Now these are floats that we're going to use. These are manual floats, so they actually have to, as the veterinarian, they'll open up the horse's mouth and they'll use these to grind on the side of the mouth onto the teeth to sand them down. Horses' teeth can get really, really sharp, and they can actually develop little hooks that can, of course, cause tongue ulcerations, problems when eating, especially if there's a bit in their mouth while they're being ridden. That can also cause odd pressure points and pain for the horse. So horses routinely have dentals starting at like the age of 2 or 3, and routinely at least once a year having a dental float, sometimes every 2 years. It really just depends on the horse. And again, we're using these dental floats. They're basically rasps. So there's like a nail filer at the end, and we'll use that to grind down the sides of the teeth so that they're not sharp and pinching on the inside of the horse's mouth. And again, these are ones that we'd actually have to manually do it. They do make ones that are electric now. And they'll do it for us, so we don't have to take so much effort to manually float the patient. All right, and I actually have a flotation video. I wanted to show you guys what it looks like, how they're going to float this horse. A little bit different than our dogs and cats. We will sedate the horses, but they're not going to be under full-blown anesthesia, which is what we do for our small patients. So it's a kind of a different world, definitely a different procedure. We don't grind down or file dogs and cats' teeth. We scale and polish them. But with horses, we actually do grind, kind of sand them down a little bit. So we'll watch this video about the tooth float, just so that you guys can get an idea of what it looks like. So this horse is sedated. He is very sleepy. When horses are sedated, they are not going to drop to the ground. They can fully stand while they are heavily sedated. Sometimes we'll put them in stocks to support them. So this guy has a manual file and he's going up into the mouth, and you can hear him sanding down, kind of grinding down the teeth. This horse, this contraption that he has on the horse, this is to hold open the mouth while he's doing this dental float procedure. So this instrument makes it to where even though the horse is biting down, they can't close their mouth and bite the veterinarian. It'll stop them from doing that. Because he has to feel the teeth. Is it still sharp? Is it not sharp? Do I need to file more?
Nice.
When horses' ears are right off to the side like this, they're nice and relaxed. This one's like, what are you doing? And it's just nice and easy, very gentle. We don't want to spook or scare the horses. They do have some light sedation, but of course these patients are 1,000 to 2,000 pounds. So putting in that mouth gag, holding that open. He does that on a few horses, but you guys get the point there. A little bit different than, again, with our small dogs and cats. This is what's called a dental scaler. This instrument we're going to use on small animals to remove plaque from their teeth. We do have the electric scalers, which we're going to use to really clean the teeth off with. Yeah, I love horses, you guys. I grew up riding horses, showing horses, big part of my life. And when I got into the veterinary field, I worked in equine medicine for my first 4 years in the field. I actually went down to Kentucky. I worked with racehorses. It's really, really exciting and fun to work in large animal. And if you guys are interested in that, that's something for your externship. You can work with large animals. That is an option. So just keep that in mind if that's something you'd like to do. So this dental scaler here, again, we're going to use this to kind of go over the teeth, and we can knock off big pieces of plaque and tartar with this tool. We're not going to use this on our large animals. And we do have electric scalers. So this is kind of just to remove the big chunks. And then we have an electric scaler, which actually will shoot water out of the end of it. And with that pressure, that's what's going to really clean off the teeth. This is another oral instrument, not necessarily for the dental or for the teeth, but we use this in livestock medicine. This is called a drench gun. So we'll use these in our smaller ruminants, which are known to be like our goats and sheep. And this device, it's really similar to like an oral medication syringe. So what they'll do is they can put a large amount of oral, let's say it's dewormer, because that's a very common oral solution that they'll put in these drench guns. They're going to treat, 10, 20, 30 goats or sheep with one fill up of this drench gun. So they can kind of set it on a setting to where they're only giving X amount per dose, so that they can dose their entire herd with that deworming medication. These are pig tooth nippers. So we're going to use them on our baby pigs to remove what we call needle teeth. So when they're born, they have really, really sharp teeth, just like needles. I mean, they totally puncture and can damage both themselves or their mama. So while they're nursing and they're on their mama, especially if they have significant human interaction, then we are going to kind of nip off the ends of their baby teeth, of the needle teeth, so that they're just not sharp anymore. They do look a lot like pliers. This is the
So
oral
when
speculum.
when baby pigs are born, that's the first thing they have to do is just remove those sharp teeth.
Yep, it's similar to like in our dogs and cats, well, more for the dogs, like the tail docking or the ear cropping, that's done when they're really, really young as well. So it's kind of a similar procedure. We do that, of course, to protect the mamas as these pigs are nursing. And we also don't want them to accidentally injure another piglet with these teeth. We don't want to expose them to blood that early on. So yes, it's a common thing that we do. Again, this is like right as soon as they're born. So it's not something that, they're going to be scarred and remembering the rest of their life. Usually in infancy, it's something that they get over rather quickly. But yes, absolutely. Right after they're born. So we just saw this oral speculum on the horse. So this is similar to like a halter. This is going to go up and around the back of the horse's ears and holding onto their face. This is going to go over the bridge of their nose, and then their top teeth are going to sit on one end. The bottom teeth are going to sit on the other. And then it has kind of a crank tool over here, so we can crank it open, have the mouth that is fully open so that the doctor can reach in there, feel around on the teeth. How sharp are they? Do I need to float or sand it down a little bit more, or remove any hooks inside? So some horses we don't have to use them for. You saw that veterinarian was like fully shoving his hand up in some of the horses' mouths and they weren't biting down at all. Other ones you do have to use it with. So it's kind of case by case. These horses are going to be sedated. But yes, this is what we use, what they primarily use with the horses while they're doing this dental flotation procedure. And the dental float, that just means to grind down the teeth. Now, this is an oral speculum that we use on our small animals, so our dogs and cats. So this has a spring system here. So we'll press down on the two ends here and they'll come closer together with that spring. And then we'll set the canines, the top and the lower, into, there's kind of a little hole at the ends over here. And then when we release the pressure, the spring will then come back to its fully extended state, and it will extend the mouth so that they hold it open while holding it on the sides so that we can go in and clean their teeth, especially if we're pulling a tooth, then we'll need to use something like this. Now, they've kind of started to get phased out, especially these metal oral speculums, because they were causing a lot of jaw pain and problems with patients post dental procedure. So kind of what's being more used now is like smaller plastic tubing, just like a more gentle way to open the mouth so that they're not so sore after the procedure. So you may or may not see these. Again, they're kind of getting phased out, but some older practices still might be using them. All right, but we're going to stop here for the lecture for today. So again, we're almost up to slide 60. The next time that we meet, we're going to be going into bandage tools and just some more equipment that we're going to use for our animals.